Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Today, we're diving into a collaboration that doesn't always get the spotlight, but can make all the difference. That is, your relationship with a pharmacist. Joining us is Kate McCarthy, a pharmacist who works exclusively with patients with rheumatic disease. From navigating complex medication regimens to overcoming insurance hurdles and guiding patients through biosimilar transitions, Kate shares how pharmacists are integral to improving outcomes in rheumatology. This conversation might change how you see what happens after your prescription is written. Kate McCarthy is a clinical pharmacist at the University of Rochester Medical Center. She completed her studies at Cornell University and pharmacy degree at Albany College of Pharmacy and Health Sciences, followed by an ambulatory care residency at the University of Rochester. She serves both pediatric and adult patients with rheumatic disease from the University of Rochester Specialty Pharmacy to help improve medication access, education, and engagement. She's also a pharmacist educator, author, research mentor, and works with the ACR on its medication guides and on the ACR Interprofessional Practice and Management Committee. Enjoy. Kate, welcome to the show.
Hi, thanks for having me.
So I wanted to talk a little bit about what is the pharmacist's role in caring for patients with rheumatic disease. Can you talk a little bit about the scope of things that you can do to try to help our patients get better control of their rheumatic diseases?
Absolutely. So, our main role is really to optimize medication therapy and ultimately patient outcomes, which hopefully is their overall well being for rheumatic conditions. So, it really can vary depending upon the practice setting and the needs of patients and providers, but we really try to help fill in gaps to improve access to care, adherence to care, focus and hopefully minimize any side effects, adverse reactions, and really can help optimize care with some dose adjustments and follow up and monitoring. So, hopefully, really to optimize patient outcomes overall.
That sounds awesome. I noticed that you're a board certified ambulatory care pharmacist, BCACP. How does that degree prepare you to work with patients with rheumatic diseases? And is that something that every pharmacist has? Or are there different trainings that different pharmacists may have?
Yeah, absolutely. So there's a whole host and variance in training. So our board certification really depends upon your general practice area. So currently there's an ambulatory care board certification, which is the BCACP. There's antibiotic and stewardships, there's oncology, a wide range. Rheumatology is probably a small, tiny little piece of the ambulatory care for a pharmacy perspective. So, really focuses more on chronic disease management, cardiovascular disease, diabetes, respiratory infections, the whole nine yards. So, it really helps me approach the patient as a whole, kind of being able to balance their rheumatology disease with everything else that they may have comorbid disease states. So, how do you approach a diabetic patient when you need to add on steroids?
Oh, awesome.
Yeah. I've had to do a lot of additional kind of self education, but really it's kind of the backbone of my pharmacy education.
And just to clarify, are you employed by the hospital and you serve the Division of Rheumatology and other specialties or just rheumatology?
So, my role is just rheumatology. So, I'm part of the University of Rochester health system. So, I split my time actually between the pharmacy and then the rheumatology clinic. We
Ah,
kind of
okay.
divide out by various disease states to really focus on one area and those dedicated patients.
Interesting. I know we also have a group of pharmacists that work with us in the hospital that I'm at. I wonder, is that a common thing that hospitals have pharmacists assigned to rheumatology practices?
It's definitely growing. I think when I started almost 10 years ago, I could probably maybe reach out to a few colleagues who had a similar position, and now we have quite a few
Oh,
who've
that's
grown into
interesting.
these roles. Even within our own health system, it's grown for me to multiple pharmacists all dedicated to the rheumatology.
That's amazing. And do you have any idea? So, in big hospitals, it sounds like pharmacists have become increasingly present in the rheumatology space over the years, as you mentioned. Do you have any idea what happens in like private practice? If I have my own rheumatology practice, do I employ pharmacists or do I have any access to pharmacists if I'm not in like a university or academic healthcare system?
That's a fantastic question and probably area for opportunity. I know of a few colleagues who work like with a pharmacy school and then would have a practice in a private practice setting.
Ah,
So they're able to kind of split their time that way and hopefully have access that way. But it's probably not as common as a health system. So probably a great area for opportunity.
great, because I've increasingly found it so helpful to have my pharmacist. They're on my speed dial whenever I have any issues with getting medications approved or getting patients to take medications. I mean, there's so many roles. And sometimes just last week, one of my pharmacists reached out to me telling me that the patient that was on Humira, the efficacy of the medication seemed to be waning before her next dose and to consider changing the medication. And I was so impressed by the fact that my pharmacist was contacting my patient independent of me and making sure that she's taking the medication and making sure that she's responding appropriately to medication. I was so happy to get that email from her. And I'm setting her up to see her this week to try to figure out whether we need to change the frequency of medications. It's such a pleasure and such a benefit for patients to have pharmacists around.
Yeah, I think that's really where we kind of help and fill in the gaps. We call them so often for refills, or I feel like we're on speed dial for the patient. So if we can help flag any issues, concerns, significant changes like that, they may only have annual appointments, but something like that may come up, or they forget to schedule an appointment and really probably should be seen. So,
Yeah.
or labs that they constantly avoid, or kind of that reminder.
What do you think are some of the best ways that rheumatologists and pharmacists can work together and collaborate to care for patients? How should that process best work?
Really may depend upon the provider and their practice. We really tried to help wherever they've needed. We're kind of open to any medication management that would ease their workload. We took a lot of the injection trainings from the nursing team just so they could dedicate their time to the infusion center instead. So we really could do all the medication education, counseling. Essentially, once the provider and patient kind of decides on the preferred therapy, we fill in the gaps and make that happen.
Amazing. So, do you actually have face to face meetings with patients to walk them through the injection process, or do you do it virtually or both ways?
Since COVID, all of the above. Ideally, we like to meet in person just so we have the trainer devices. They can kind of get some of those nerves, make sure there aren't any issues with the first dose and they tolerate it well. So normally we try to meet in clinic, walk through, have them start right then and there. But we serve just such a large geographic area that some of the elderly, it's just not possible. So we'll do that through telemed. We have a bunch of resources we'll send them, walk through anything that they may need or help them feel comfortable to get started. And then same for afterwards. Things come up, site reactions, questions, dosing, timing, all that. We're always there to help.
Amazing. So, one of the first contacts that I reach out to my pharmacist is in getting prior authorizations from insurance company, which is a vein of our existence. Can you tell us how pharmacists can help with that process, or is that a role that you guys take over?
Really depends upon the practice again. For a lot of practices, yes, I think the pharmacists take ownership and submitting the PAs, helping with appeals. It can vary depending upon if it's just the subcutaneous prescriptions and DMARDs versus the infusions, which can be a different battle through prescription versus medical coverage. We're lucky enough to have a dedicated PA pool in our institution. So they do all the initial prior auths, but we'll still follow up and make sure that they're back for when the patients need it. They're not lingering to start months down the road. And same for appeals. But yeah, it's definitely a bane for everyone.
That PA pool, is that pharmacists or who makes up that PA pool that you mentioned?
They're technically not pharmacists. They're, I would say, medication access. So they're not fully clinical. So the provider has, we use smart forms and templates. So they'll put in all that information. So they really do the logistics of submitting it just to insurance.
Can you tell me tips? So I take care of a lot of patients with rare autoinflammatory diseases. And for many patients, there are no FDA approved medications to treat them. And I often prescribe them medications off label. Do you have any tips in how to get those PAs approved for things that, have no FDA indication?
Great question, because I gotta love PA's templates where if you don't fit the block, then it's automatically denied. So a lot of times that is an unfortunate first step. But we do a lot to dig up studies and uses in other patients and those rare individuals that you can then submit with the appeal to get that approved afterwards. So, a lot of those difficult or rare patients, a lot of times we'll reach out to our colleagues to say, hey, do you have any information? Do you have any similar patient cases? Anything that you can share to help in these scenarios? So, having that network is extremely helpful.
Amazing. And how are you guys handling sort of this recent switch to biosimilars? I'm getting all of these emails from my pharmacist saying, "Oh, can you please change Humira to, I don't know, any one of the dozen, it seems like a dozen of biosimilars." How are you guys coping with that? And are you seeing any challenges in first, like patients being okay with switching once, if they've been stable on their medicine? And have they reported any complications or any challenges with new medications that you've seen?
Great question. This has probably been a good bulk of our work over the past few years,
Yeah.
year. So, with kind of the complexity and some biosimilars being technically interchangeable and others not from the FDA, to really kind of minimize our provider workload and just asking for so many different prescriptions. So, we actually took a different approach. We collaborated with our provider group and started a collaborative drug practice agreement, so CDTM. So essentially, we signed an agreement with the providers, and then we have the patient sign the agreement as well. And when the provider decides to start Humira or adalimumab, they would notate that. And then from there, we would determine which one is preferred, which is the best option for the patient, cost wise, tolerability wise, with all the citrate free products. And we would really kind of take everything from there, and we can actually prescribe under that agreement and as well.
That's amazing. And what about for patients who have loved their Humira for years and now you're telling them that they have to switch to one of the biosimilars? How do you counsel patients or how do you approach that?
Yeah, we've definitely taken on the bulk of that counseling, just explaining to them that it's the same product, essentially made by two different companies, the similarities, the differences, and the nuances. I feel like when you kind of really counsel patients and explain it overall, they're much more receptive. There's definitely a handful of patients that have been on it for years and won't even consider switching. So we help with those prior auths if that's what it takes as well. And there's a couple cases where just the biosimilar is just not as tolerable or site reactions come up. So we can always help switch them back if needed.
Got it. So there are options if the patient sort of refuses to be on a biosimilar to submit a PA and see if brand name Humira can get approved, for instance, or if they've had reactions to some of the medications or don't seem to tolerate it as well. I guess there's options to switch them to either the original one or maybe a different biosimilar.
hmm
Got it.
Exactly.
And many of our medications are difficult to take or have complex dosing regimens. I can think of methotrexate that you have to take all these little pills like once a week, or even some of the biologic medications. Some of them require higher doses at the beginning and then you spread it out. How do you work with patients to assist them in making sure that they take their medications the right way and try to improve medication adherence?
Yeah, so really the counseling to begin with, once again, we use every trick in the book. Pill boxes, help them set those up, flag their methotrexate days, fill in the folic acid on everything else.
Mm.
We do calendars, help patients with apps if that's their forte and go to. When we do teaches, having them set reminders in their phones, essentially whatever works for the patient will help them get set up and get started. And then we'll follow up for refills so we can really kind of flag any adherence issues too. They have more or less on hand than we anticipated what happened.
Uh-huh.
So we try to tease out some of those issues when they come up as well.
Awesome. And many of our medications require sort of frequent monitoring, like methotrexate every 3 months. Do you guys help in making sure that the patients are getting the regular? Can you guys help with issues like that, making sure that they get regular monitoring?
Yeah, we definitely provide reminders of you're overdue from labs or blood work. Make sure the lab orders get to an outside location if that's closest and most convenient for them. All the baseline labs needed for the biologics, TB and hepatitis testing, make sure all that gets done ahead of time. So absolutely, we definitely help. Remind
Right.
patients is half the battle and then getting those results back.
And I'm wondering, just like I mentioned, that my pharmacist was contacting my patients without my knowledge and letting me know that her Humira wasn't working as well as it should. Are you sort of independently contacting patients to try to assess their adherence and if they have any medication issues? Or are you getting messages from the rheumatologist saying, oh, I'm concerned about this patient's medication adherence? Or how should it work?
Actually, probably both ways. So we reach out for refills monthly or every 3 months, either by phone, electronic means like my charts, things like that. We can detect any issues there, but we absolutely, patient comes in for a visit and something else comes up. So we'll get messages from providers all the time. They're confused about this or they're having certain side effects. They may need to switch from oral to subcutaneous methotrexate. Can you help? So absolutely, we can jump in and provide some of that training and additional education.
Great. And one of the other challenges that we often face is, for instance, I take care of kids and sometimes they're transitioning from like their parents' insurance to their own insurance, or adults are changing jobs and they're switching insurance companies. They've been on a biologic and we've had the medication approved and now they're switching to something else. What can we do to try to sort of facilitate that transition of care from one insurance to the next to make sure that they continue receiving their medications and that there's no lapse once they switch to a different provider?
Yeah, absolutely. I feel like all the insurance changes are pretty frequent. I feel like everyone's change from when they retire from commercial coverage to Medicare is like a year-long panic. So as they're researching all the different Medicare plans, we try to help fill in any financial assistance as well. Sometimes it's unanticipated. You unfortunately lose your job and then you don't have any coverage. So I'll help them get enrolled in patient assistance programs to kind of bridge that gap, get the new prior auths up and running once they have coverage again. The pediatrics to adults is, I feel like, a huge topic across the board. We have a lot of kids that we followed since they've been in young grade school, middle school, high school, and they're graduating. And how do you get their medications when they're off at college? So
Yeah.
they should be enjoying college. So we try to help make that as seamless as possible.
Amazing. You mentioned something that is hugely important, which is the cost of medications. And sometimes we want to prescribe biologics or more expensive medications to patients, and they may not be able to afford the copay. How should we think about approaching those patients? Are there ways for them to still get the medication that we want? You mentioned like patient assistance programs. So if you could talk a little bit about that, or how should we work with pharmacists to make sure that patients who require sort of more advanced therapies get their therapies, even if initially they may be unable to afford them?
I think that's a huge part of what we do. So we help patients sign up for copay assistance and then a lot of other financial assistance options that can depend upon the state and what insurance they have, but really knowing our resources, we kind of help guide patients through all that, help them apply to different programs. And I've honestly found it's just the follow up. There's so many questions to fill out certain applications. And if you don't dot your I's and cross your T's, you're going to get denied. So just following up to make sure that all that actually goes through, I feel like is half the battle.
So, talk just a little bit more about those patient assistance programs. Is that something that the pharmaceutical companies offer patients to cover the cost of copays? And who qualifies for that?
So we use a lot of patient assistance programs for Medicare patients that don't qualify for copay assistance. So it'd be directly through the manufacturers. So typically, the patient has to submit an application. There's a provider form and prescription as well. So we help coordinate and put that all together to make sure it's a full application that gets received and hopefully approved. There's also independent grants that can open up. For rheumatology, it's typically just maybe days out of the year. So we try to track patients. So when we get those brief windows, we can kind of do everything possible for as many patients as possible to help with their costs. Those are usually kind of grants for, a couple $1,000s, depending upon the disease state that they can use towards any of their
Hmm.
prescription drugs. When we really get stuck, we try to open the box, and maybe one drug as an injection might not be cost effective through their prescription coverage, but the same thing through their medical benefits through an infusion might
Hmm.
be a drastically different copay. So we'll try to reach out to the provider to see if maybe that's an alternative option just to keep the door open.
And are all patients, do all patients qualify for these copay assistance programs? Do they need to be on certain types of insurance, or do they need to have certain incomes, or how does it actually work?
Unfortunately, yes. So, copay assistance is not typically income dependent. That's strictly for those with commercial coverage, but there's even caveats there, and there's a whole different types of commercial policies now that have really gotten complicated, like maximizer policies, and it's a whole new world out there. And then for any federally funded programs, unfortunately, those are mostly income based. And this year, with the changes to Medicare, they've lowered the income eligibility for a lot of the programs. So it's definitely been a difficult year. So just helping patients kind of navigate. Sometimes they have to rethink their budget as well, and we're lucky enough through our health system that we have other financial assistance options that we can utilize if we really get stuck too.
Got it. So, like the hospital itself may have some funds
Mhm.
to provide for the copays or things like that. Yeah, it's crazy. I mean, this whole issues of the cost of medications. I've heard it that medications cost more in the United States than anywhere else in the world, and that we are basically funding all the R&D of the medications, and then everybody else gets the benefit of it because they get cheaper prices, but the US still spends quite a bit of money on all of these medications. And hopefully there'll be some change coming. I don't know if you have any thoughts or perspectives on sort of the healthcare system overall and what you think should be done to try to make medications more affordable.
Yeah, I think we're finally at least recognizing the immensity of the issue, how it affects nearly everyone, especially for rheumatology. I think there's steps in the right direction, like the Medicare out of pocket limits this year have significantly helped. But for many, it's just still too much. So I think we have a lot more to go since all of our drugs are nearly so expensive.
Yeah.
Yeah, there's a lot of work to be done. I
Yeah.
empathize with my patients day in, day out.
Yeah. Can you talk a little bit about either cases that you've managed or from the literature, some evidence of like how having a pharmacist helps the care of patients with rheumatic diseases? Because I imagine, sort of in my mind, having you guys around will make my patients be more adherent to medications, detect complications earlier, and provide better care overall. I don't know if you have any sort of data or sort of experiences that show the benefit of a pharmacist care in the benefit of having a pharmacist in caring for patients with rheumatic illnesses.
Yeah, absolutely. So we worked with a lot of different health system pharmacies and their rheumatology practices to really try to identify what our changes to outcomes are. So just shout out to Vanderbilt. They've led a lot of them, but through a lot of the multi-site collaborations, we've shown just pharmacist involvement does significantly improve adherence. We're also able to tease out true non-adherence versus appropriate holds, severe infections, and hospitalization. So we've kind of worked for some of those studies and have published that. We've done a lot of work on baseline drug screening, like TB and hepatitis testing prior to starting biologic therapy. And when you have a pharmacist kind of involved and embedded in clinic, the rates of those screenings is significantly higher. In some cases 20% up to over 80 to 90% in some practices. And then we're working on the impact of biosimilars right now. How does that affect patients, time to care, access to care, and overall outcomes? So we're working to collect data on that currently. So hopefully we'll know more down the road.
Amazing. And another question about the finances of a pharmacist, because it sounds like you provide a lot of benefit. Your services are costly. I mean, you have degrees. I'm sure pharmacist salaries are not cheap. So why would a hospital or a practice want to spend more money to take care of patients? I mean, do they get anything in return in terms of, because the hospital is looking at just money, right? I mean, we're looking to care for patients, but from a hospital's perspective, they want to make sure that they're not losing money. So what's their incentive in having pharmacists on board?
Yeah, so I think probably the backbone of pharmacy has really been cost savings and cost mitigation.
Ah,
So avoiding medication errors and has really, for a lot of practices, kind of been the backbone. We also, by keeping medications within the health system, you can recoup some of that reimbursement. So that actually
mm,
pays for all of my salary and then well beyond that to support all the other endeavors and clinic practices. So really keeping kind of things within the institution, the reimbursement model has really worked well. We also try to look at formularies when we can for infusions. Is this the best option for most patients? Greatest reimbursement, but lowest cost. So we really try to focus on that when we can to just save everyone where you can.
got it. That's super interesting. So yeah, I saw that a few years ago, hospitals started having their own pharmacies, and I guess in part to sort of recoup some of that benefit that you mentioned. And I think it seems like a win-win for everybody because they always remark that when they get their prescriptions filled through our hospital's pharmacy, it's just like white glove delivery and they get calls all the time, and they're always so happy. So patients get better care, it provides for your salary, and it makes my life easier. So everybody sounds like everybody wins. I wonder, in an ideal world, how would you envision sort of improving the care of patients with rheumatic diseases so that physicians and pharmacists would better collaborate and make sure that the patients are getting the care that they need?
I mean, in the ideal world, it would be a seamless process where you could decide on therapy and the patient could start that same day. But I
Great.
think we're a long way from that. So I just having pharmacists involved to kind of speed up that process and hopefully help patients get started as soon as possible. Utilizing pharmacists for all their clinical knowledge. We're here to help with those difficult scenarios, those odd cases. Atypical adverse reactions. So it's definitely a two-way relationship. I learn new things every day, and I'm just love helping both my providers and patients.
Yeah. I feel another issue with a pharmacist reaching out to me. I had a patient on Enbrel for years, and her disease control wasn't 100%. It was like 80%. And I was like trying to get her up to 100%. And we switched her over, I think, to a Humira biosimilar. And she had this sort of allergic reaction and was in the emergency department with a rash all over her body. I felt so guilty. But what you mentioned, like working with our pharmacist to try to strategize. It's like, okay, these are the medicines that she's tried and failed, and working to try to figure out what's the next best step for her patient, and considering who she is and what comorbidities she has and what drugs her insurance company may or may not approve. I think sounds like I'm going to make that email today to my pharmacist and try to figure her out. And one last question, what excites you the most about sort of the future of pharmacy in rheumatology? At least for us, I can see that there's all these new medications and sort of more coming down the pipeline. From your perspective, what gets you excited about the future of rheumatology care?
I think that's exactly it. There's always something new. It's always growing. It's just such a novel field that I feel like rheumatology never really gets the full credit and excitement that I appreciate it for. For the pharmacy perspective, I'm excited that it's growing so much. I feel like I was a one off when I first started, but to have so many colleagues now and providers really depend upon us is, I think, huge and really rewarding. And really just to kind of grow in that role. As I say every day, it's never a dull moment. There's never dull patients, and I love the challenges and everything that it brings.
Awesome. Kate, this has been a really fascinating conversation. I can't wait to get back to work and message my pharmacist all the time. I was saying, well, Kate said that I should talk to you about when this happens. This has been great, Kate. And thank you so much for your time and for everything you do for patients. I really appreciate it.
No, thank you. Thanks for having me.
Who knew that pharmacists did so much? From medication adherence to navigating insurance barriers and even helping with transitions to biosimilars. Kate McCarthy reminded me that pharmacists don't just fill prescriptions, they help fill the gaps in care. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, please leverage your relationship with your pharmacist. And of course, stay healthy.